Chandra. This was my interest that I chose this topic on screening for diabetic retinopathy. I'm sure all of us are aware of the problem of diabetes. It didn't go away anywhere in this COVID era. We continue to have the problems of diabetes and the diabetic retinopathy complications. Uh, we have very little data on diabetic retinopathy, most of them from South India, and they range anywhere from 12% to 20% if you compare the rural and the urban areas. So there is a huge problem of diabetes-related complications in the eye, that is the diabetic retinopathy. So what should be done? Obviously, screening for diabetic retinopathy is the important thing that all of us have to do, especially in a country like India, where we have very little access to care for diabetic retinopathy for these patients. So we need to screen these patients. Clinic-based, of course, is very effective. We have been continuing to do outreach screening programs focused on diabetic retinopathy, and of course, telemedicine has played a major role in screening this diabetic retinopathy. Using tele-screening technology helps in screening for diabetic patients because fortunately, diagnosis of diabetic retinopathy is image-based, and anybody looking at the image can make this diagnosis. So patients fund us, and just for completion, I'm just showing the process of tele-screening, where the fundus images are taken from a remote site, sent to a retina specialist, graded, and the report is sent back. We've been doing this for the last 2 decades in few of the diabetic clinics where the patients, their technician takes the photo, sends it to us, we create a report after a retina specialist grades these images and sends it back. We developed our own software, which is a semi-automated software for doing this process. But what has changed in the last decade in this? Because there's been a lot of focus. People have been talking about diabetes and its importance. The prevalence of diabetes has markedly increased from 26 million in 1990s to 65 million in 2016. And if you see the recent data, prevalence of diabetes in the age between 20 to 79 has increased from 61.3 million to 77 million in 2017, in almost 7 to 8 years. And this is graph, or this picture shows clearly in the last 4 decades how the entire scenario changed. This is not just for urban, but it is even in the rural population, you see this huge change. So what has also changed is the availability of better technologies with good communication channels. You have, we started with the V-satellite connectivity, but today the broadband is available almost in every nook and corner of India, so that you can access care even from the remote villages. Large, bulky, expensive cameras are being replaced with small, cheaper, easy to use cameras, which are much more easily portable, makes it easy for us to take it to the remote locations to screen patients anywhere. And of course, with the advent of the AI algorithms in the recent last few years, there's been a vogue. I've been specifically working with the Google, myself and Dr. Rajiv Raman from Shankar Netrali have been working with this team to develop this algorithm, and it's been pretty working well. Just within less than a minute, your image is graded, and the grading levels are thrown up for anybody to see. So this has helped us in our screening. We have started using it in real time in our. So we are now able to not. I mean, the retina specialists need not spend the time, and also the diabetic clinics are able to get their information within less than a minute, so the patients do not wait to receive these reports. But what has not changed, unfortunately, still there's a lot of low awareness about the diabetic complications in the eye, especially even among the physicians. They talk about everything, nephropathy, neuropathy, but no retinopathy. For some reason, only when a patient loses the vision, they tend to get referred to the ophthalmologist. Even the patients are indifferent. Many of them don't have access to care, and of course, the cost is a prohibitive factor because it also needs a prolonged care. So who should do this screening? Unfortunately, today it's limited to ophthalmologists, while the target population, that is the diabeticists with the physicians and endocrinologists, and I've been talking or talking about the endocrinologists and the primary care physicians taking the onus of screening, and it should not be with the ophthalmologist. Unfortunately, only 1.3% of the general practitioners actually use direct ophthalmoscopes in one of the study because they don't have time, lack of awareness, and of course lack of training. So very few patients are diagnosed early on, and many of them have already lost their vision when they reach to a diabetic clinic. So I just did a few small surveys some time back where it showed that in India, compared to a country like US, where the availability of telescreening or availability of DR care is much better, we still do much less. Only 10% of the ophthalmologists use telemedicine for screening for diabetic retinopathy. So the current model for DR is clinic-based, limited to ophthalmologists. We've been doing these outreach and telescreening, as I should have told you. We've been doing this for the last few years. And we also go to the primary health centers to screen these patients because diabetic patients come to collect their medicine. So this is an opportunistic time when we could have all these poor diabetics screened for diabetic retinopathy at least once a year. They get their eye screening, and the government ensures, the primary health center doctor ensures that they do get the screening before they get the medicine. There are also some business models that developed one team from the WellCare health systems or screening almost 18,000 diabetics in a month, every month by deploying these cameras and using telescreening with remote diagnosis by the ophthalmologist for the diabetic clinics. But what are the challenges to have trained graders? Having retina specialists, time for this is a waste of their time. And of course, there's a time delay in grading and sending it back. But more importantly, there's a lot of inconsistency in grading. With the advent of AI algorithms, there are a lot of algorithms are available, and more importantly, they've been all focusing on diabetic retinopathy because this is one low-hanging fruit that everybody could work on. And then we have quite a few online, offline systems which are really good and can be used in screening for these diabetic patients. We have deployed it in real time in the physician's clinics. We have also advocated using it in anterior segment specialist clinics, where the DR screening can be done much easier and faster. So what are the future? We recently did a study looking at all the studies from Shankar Nethralaya, Arvind, and population-based studies and Mohan diabetic centers, where we looked at the data and we could see the risk factors, that is patients with high risk features, such as people within 50 to 60 years, male, gender, duration. We saw we could almost 93.5% of the patients with PTDR were having these high risk factors. So it showed if you could do some more research on this to identify this high risk target population, and you see focused screening of these patients or people could lead a lot of results in identifying patients who are prone for losing their vision. It's surprising that there are a lot of research going on using AI, and one of this is being published by Google, where they are able to predict the diabetic retinopathy, progression of diabetic retinopathy happening in patients who do not have DR, just by taking their fundus photographs. Of course, this needs a lot of longitudinal data, but it looks like there is a possibility you'll be able to identify diabetic patients early on, even before they develop retinopathy. Of course, there are a lot of biomarkers being identified, but more interestingly, seems to be, just by taking external eye photos, people are able to identify, or it appears there is a possibility you may pick up some of the posterior segment diseases. Of course, this appears very futuristic, but looks like there is a possibility. Of course, with home OCTs and different technology developing, we will find much easier way to reach these diabetic patients early on before they lose their vision. So as I said earlier, the onus of finding the DR cases should be with the diabetologists and physicians, and ophthalmologists should work up with them. And using these technology will play a major role in early identification and preventing the loss of vision. I want to thank the organizers again for this opportunity. Thank you, Chaitra.
Thank you, sir. It was indeed a